Good afternoon, everyone. COE STM welcomes all the participants for today's RDLS session. Today's topic is management of sexually transmitted infections and reproductive tract infections in PLHIV, and the speaker is Dr. Prasanjit Saha. Dr. Prasanjit Saha, sir, has done MBBS, Diploma in Maternity and Child Welfare, and Fellowship in HIV Medicine, and is currently working as the Senior Medical Officer at the ART Center, Medical College and Hospital, Kolkata. Since 1998, he has served as a key resource person, facilitating numerous trainings and workshops for healthcare professionals across various forums. Dr. Saha's expertise spans community health, STD and HIV, sexual health, and drug use disorder. He has also been empaneled as the Saksham Expert Master Trainer for the Global Fund Round 7 at the University of Calcutta. We welcome you, sir, for today's session and request you to start the session.
Uh, Thank you, Shweta ma'am. Good afternoon, everybody. Today's topic reads Management of Sexually Transmitted Infections and Reproductive Tract Infections in PLHIV. What are the contents of this session? It includes introduction, transmission and relationship between STI and RTI and HIV, syndromic approach to treat common STI-RTI syndromes, common syndromes, which includes urethral vaginal discharge, genital ulcer, scrotal swelling, etc. Introduction. Sexually transmitted infections or reproductive tract infections are important public health problems in India and across the globe. Sexually transmitted infections can be defined as a group of communicable disease transmitted predominantly through sexual contact. So it can be transmitted by other methods as well. WHO tracks for curable STI, which includes syphilis, gonorrhea, chlamydia, and trichomoniasis. Data from the STI-RTI control and prevention program suggests significant decline of bacterial STI, which includes syphilis, gonorrhea, chancroid, increasing viral STI, that includes herpes, genital warts, hepatitis B and C, status quo of trichomoniasis, and significant burden of lower RTI, that includes bacterial vaginosis and candidiasis. Some of the STI-RTI increase the risk of acquiring and transmitting HIV infection by 3 to many folds. Transmission and acquisition of STI. The three important pillars in this transmission and acquisition should we remember, that is, it is the infectivity of the host or infectiousness of the source. Secondly, it is the susceptibility of the recipient and gender. These three are very important pillars in transmission and acquisition. They are, may I repeat, one is infectiousness of the source, second, susceptibility of the recipient and gender. And from an STI infected partner, infection can be transmitted through sores or ulcers, discharge from penis, vagina, anus, rectum, and oropharynx. Transmission occurs during unprotected sex, that is vaginal, anal, or oral sex, from an infected parent to newborn, and by using unsterilized medical equipment, transfusion of untested blood and blood products. Lack of hygiene also contributes to this transmission acquisition vicious cycle. This includes poor genital, menstrual, coital hygiene, medical procedures in and around the reproductive tract without precautions, physician intervention, example, IUD insertion without proper infection control, and illegal abortions. Transmission. RTI usually are not transmittable to partners, whereas STI are. But both infections are mostly seen in and around the reproductive tract area. Hence, we can say all STI can be said to be RTI, but not all RTI are STI. Asymptomatic clients can have STI and can transmit the same to their partners. STIs are transferred more from men to women or other genders as women are receptive and have a larger surface area, a longer contact period, and exposure with pathogens. Relationship STI, RTI, and HIV. Cofactors effects on HIV acquisition and transmission. HIV infection is predominantly sexually transmitted in India, around 94%. Presence of STI and RTI increases the risk of HIV acquisition and transmission due to three factors. They include loss of epithelial integrity when there are ulcers or abrasion, recruitment and activation of inflammatory cells around that area, and immune dysregulation. STI and RTI in HIV positive people can increase the viral load. A high viral load increases efficiency of HIV transmission risk to others. Interactions between STI and HIV. Let's see this vicious cycle. High risk sexual behavior leads to increased transmission of STIs and HIV, progression to clinical disease. So with HIV, there's impaired immunity in that person. And when you have STI with impaired immunity, what happens? There would be altered frequency of and natural history would be distorted and increased susceptibility. This vicious cycle goes on. Impact of STI on HIV viral load. Urethral HIV DNA more than doubled when there was also the presence of STI, for example, gonorrhea. However, treatment of gonorrhea cuts the urethral HIV DNA in half, almost the same as those without STI. The average effect of STI co-infection on viral HIV viral load in individuals on ART is minimal and thus unlikely to decrease the effectiveness of treatment as prevention. However, there is not enough data to rule out the possibility that particular STI poses a larger threat. Let's see this data. STI infections, and on the right side column, we have genital viral load. So when there's no gonorrhea, the genital viral load is around 19%. When there's gonorrhea, before treating the gonorrhea, the genital viral load is 44%. And when the gonorrhea has been treated, that is post-treatment, and the genital viral load has been reduced to half, that is around 21%. Common symptoms and signs of STI, RTI in women. So what are the symptoms and signs in women? They are excessive, abnormal, yellowish, greenish, foul-smelling, fishy-smelling vaginal discharge, itching, rashes, sores, blisters, ulcers in genital, perianal, oropharyngeal area, swellings in the groin and vaginal area, lower abdominal pain or PID, frequent urination, pain or burning while passing urine, pain while having sex, dyspareunia, and sore throat. A patient can have either or multiple of these symptoms or signs. Common syndromes of STI, RTI in women. The symptoms of vaginal discharge syndrome is vaginal discharge syndrome, and the commonest etiological agent are trichomoniasis, candidiasis, bacterial vaginosis. Symptom cervical discharge syndrome, cervical discharge syndrome, and the etiological agents are gonorrhea, chlamydia, trichomoniasis, herpes simplex. Symptoms lower abdominal pain in female or pelvic inflammatory disease in female. Syndrome is PID or lower abdominal pain. And the common STI, RTI are gonorrhea, chlamydia, mycoplasma, Gardnerella, anaerobic bacteria. Ulcers in the genital anorectal ulcers, genital ulcer syndrome, and the causative agent are syphilis, chancroid, genital herpes, LGV, and Ganoderma inguinale. Symptoms anorectal discharge syndrome, anorectal discharge syndrome caused by gonorrhea and chlamydia. Throat irritation or infection caused by gonococcal pharyngitis, causes are gonorrhea or chlamydia. Genital skin conditions. Syndrome is genital skin conditions syndrome, and the causative agents are genital wart, molluscum contagiosum, pediculosis pubis, scabies, genital and Norwegian scabies. Common symptoms of STI RTI in male. They are sores, ulcers, blisters in the genital, anorectal, oropharyngeal area, swellings in groin and genital area, rashes around genital area, anal opening and mouth, frequency of urination, burning pain while passing urine or motion, discharge from genital or anorectal area, inflammation or infection around anus or rectum, sore throat, all contributes to this symptoms. Common STI-RTI syndromes in men. Urethral discharge is the symptom. Syndrome is urethral discharge syndrome caused by gonorrhea, chlamydia, trichomoniasis. Genital ulcers is genital ulcer syndrome caused by chancroid, syphilis, genital herpes. Inguinal bubo is the inguinal bubo syndrome caused by LGV and chancroid. Scrotal swelling is the painful scrotal swelling syndrome caused by gonorrhea and chlamydia. Anorectal discharge and throat irritation. The syndromes are anorectal discharge syndrome and gonococcal pharyngitis respectively, and both are caused by gonorrhea and chlamydia. Genital skin conditions. Syndrome is genital skin condition syndrome caused by genital warts, molluscum contagiosum, pediculosis pubis, genital scabies, and Norwegian scabies. Let's see the STI-RTI syndromic case management. What is a syndrome? It's a constellation of signs and symptoms. We sort of put all the similar symptoms in the same group. So it helps us to treat all the symptoms and signs. And as a result, some of the bacteria or other organisms are treated at the same given point of time. So let's come to the first syndrome, that is urethral discharge syndrome. And what are the symptoms? It is there are pus or a mucopurulent discharge from the penis, pain or burning while passing urine, increased frequency of urination, symptoms like malaise, fever, and the drug of choice are azithromycin 1 gram, OD stat plus cefixime 400 mg OD stat. It is there in the kit 1, gray kit, and you have to treat all recent partners. Next is the cervical discharge. So nature and type of discharge, quality, quantity, color, and odor, burning while passing urine and increased frequency, genital complaints by sexual partners, low back ache, take menstrual history to rule out pregnancy, and the treatment of choice is same. It is azithromycin 1 gram OD stat plus cefixime 400 mg OD stat. And the kit is gray in color and it's kit 1. Treat partners when symptomatic. Let's come to painful scrotal swelling. It is swelling and pain in the scrotal region. There's pain or burning while passing urine. Systemic symptoms like malaise and fever. Past history of urethral discharge. It is suboptimally or incompletely treated urethral discharge syndrome. The drug of choices are azithromycin 1 gram OD stat plus cefixime 400 mg OD stat. Everything should be under direct observation treatment. And the kit is kit 1, gray in color, treat all recent partners. Now let's come to the in female vaginal discharge. Nature and type of discharge, quantity, color, and odor has to be looked into. Burning while passing urine, there would be increased frequency. Genital complaints by sexual partners, low back ache, take menstrual history to rule out pregnancy. And the drug of choices are sectinidazole 2 gram OD stat plus fluconazole 150 mg OD stat. And the kit is green in color and it is kit 2, and treat all partners when symptomatic. Genital ulcer, that is non-herpetic. So genital ulcer, single or multiple, painful or painless. Remember, the commonest cause of genital ulcer non-herpetics are usually syphilis and chancroid. usually. And syphilis is caused by Treponema pallidum, and chancroid is caused by Haemophilus ducreyi. And there would be burning sensation in the genital area. There would be enlarged lymph nodes. And the drug of choice are injection benzathine penicillin, 2.4 mega unit in one vial. You have to divide the dose 1.2, 1.2, and you have to give intramuscular, deep intramuscular into buttock, and has to be given after proper skin test. Look into the sensitivity. Only then you can push the injection, and give azithromycin 1 gram single dose. And the drug and the kit is kit 3, white in color, and treat all sexual partners for past 3 months. If a person is allergic to injection penicillin, you can give doxycycline 100 mg BD for 15 days plus azithromycin 1 gram single dose. But if a woman is lactating or she is pregnant, you cannot give doxycycline. In that case, you have to give erythromycin stearate 500 mg 4 times a day into 15 days. Please keep that in mind. And the kit is blue kit, that is kit 4, and treat all sexual partners for past 3 months. Genital ulcer herpetic caused by herpes simplex virus type 2. There would be genital ulcer or vesicle, single or multiple, painful or recurrent, burning sensation in the genital area. If the drug of choice is acyclovir 400 mg, has to be given 3 times a day into 7 days. Color of the kit is red in color, it is kit 5, and no partner treatment is necessary. Lower abdominal pain, LAP, or also known as pelvic inflammatory disease in female. What is lower abdominal pain or PID? Any infection above the level of cervix that includes endometritis, salpingitis, tubio-ovarian abscess, and peritonitis constitutes lower abdominal pain or pelvic inflammatory disease. There would be vaginal discharge, menstrual irregularities like heavy irregular vaginal bleeding, dysmenorrhea or painful bleeding, dyspareunia or painful coitus, dysuria, tenesmus, lower backache, cervical motion tenderness. And the drugs of choices are cefixime 400 mg OD stat dose, metronidazole 400 mg twice daily into 14 days, and doxycycline 100 mg BD into 14 days. Remember, in the first trimester, metronidazole should not be given, and doxycycline should not be given in pregnancy or when the mother is lactating. And remember, it's very difficult to take for 14 days. So antiemetic and PPI has to be added. Otherwise, it's very difficult to take these medicines. And the kit is yellow in color and it's kit 6. Treat male partners with kit 1. Inguinal bubo. The swelling in the inguinal region, which may be painful, preceding history of genital ulcer or discharge might be there. Systemic symptoms like malaise, fever, etc. might be present. Drug of choices are azithromycin 1 gram, doxycycline twice daily into 21 days. It's black kit that we would give, kit 7, and treat all sexual partners for the last 3 weeks. Syndromic management. There has to be comprehensive medical treatment. I just want to say something. There was this Mawanza study in Tanzania, and in the study, they found out if we go for early diagnosis and treatment by syndromic management of STI, there would be 40% reduction of acquiring HIV infection or 40% reduction of HIV infection. So the Mawanza study in Tanzania told us, gave us some insight that early management of STI by syndromic approach reduces STI by 40%. So this is very, very important and pertinent in today's time as well. So comprehensive medical treatment is very important. Follow-up written in 3 to 21 days. More frequent if symptoms persist. STI need partners treatment, while RTI does not require partner treatment unless partner is symptomatic. Rule out presence of other STI. There can be at the multiple STI at the same time. And voluntary HIV testing and counseling at ICTC is a must. And counseling and education When I said must, it is voluntary, by the way. We can always refer. We cannot, it's not mandatory. We cannot push the person to go for the test. It's always voluntary. Counseling and education on safer sexual practices, risk reduction strategies. What is risk reduction strategies? To, to implement other strategies where the risks would be reduced. For example, a person who is PWID, who inject drugs. So if we go on letting him go on injecting drugs, there would be chances of getting him acquiring bloodborne infection like HIV, Hep B, Hep C. If we go for needle syringe exchange program, or we go for OST program like opioid substitution therapy, where we give buprenorphine sublingually, we can prevent bloodborne infection of STI like Hep B, Hep C, and HIV. So these are risk reduction strategies which has to be implemented, and NACO is doing that. There should be behavior modification. Condom promotion and provision is very important. And mind you, only condom promotion and provision is not 100%. We have to tell and explain about condom, how to go for condom demonstration, and condom should be used correctly and consistently. This is very, very important. Proper documentation of STI and RTA has to be made, and regular screening for syphilis, Hep B, Hep C, wherever available, should be noted down. What are the essential steps of STI, RTI syndromic case management? History taking is very vital, so we should do that. Clinical examination, genital, oral, and anorectal, apart from general examination, has to be done. Appropriate syndromic diagnosis as per syndromic flow charts. Minimal lab tests wherever available. Early and effective treatment, preferably single dose and directly observed treatment, has to be made, and that would reduce transmission of HIV infection. I just told you about the Moanza study. Number 6 is promotion and provision of condoms with condom demonstration. Counseling for behavior change and risk reduction. Referral for syphilis screening and HIV counseling and testing. Partner notification and management is part of the whole ball game. And remember, we have to go for partner notification, contact tracing, and cluster testing if necessary. And follow up as per schedule. Documentation of cases, details, and lab results are very important. What are the advantages of syndromic management? Why should we go for it? Because the advantages are fast. The patient is diagnosed and treated in one visit. Patient need not come on the second day to get the medicines for the treatment. The moment he or she visits, he'll get the treatment immediately. It is relatively inexpensive, doesn't need much money. The patient need not wait for lab results. He or she will get the medicines immediately. All possible STI causing common symptoms and signs are treated at the same time. As I told you, it is a constellation of all signs and symptoms caused by different organisms. So some of the organisms causing the same sign and symptoms are taken care of at one go. Scientifically proven strategy in many parts of the world. Easy to learn and practice by healthcare workers. And it can be implemented by healthcare providers at all levels of healthcare. It can be done by doctors, nurses, and any other healthcare. You do not need very higher trainings. You do not need fancy lab facilities. So there's standardization of treatment regimen. So these are the positive sides of syndromic management. What are the limitations? What are the cons? Not useful in asymptomatic individuals. We don't know whether the patient is suffering from STI, so we don't treat the person. Overtreatment. We overtreat the person. There can be side effects. There can be, due to overtreatment, there can be sometimes drug resistant as well. Cost of overtreatment and side effects. Potential for antibiotic resistance development, I have just told you. Poor sensitivity and specificity. But having said this, we know the advantages are far more than the side effects and the limitations. Urethral discharge. Usually, history of unprotected sex awake before presenting with complaints of urethral discharge. Since there is visible purine discharge, treat for gonorrhea and chlamydia as per syndromic flow treatment chart. This gonorrhea and chlamydia are the usual causative agent of urethral discharge. The discharge can be from frank purulent to serosanguinous and from copious to scanty. In the morning, if it's gonorrheal discharge, you can see this morning glit, profuse white discharge in the morning, known as morning glit. This syndrome has the shortest incubation period ranging from 1 to 7 days. It is considered a proxy for STI incidence and warrants epidemiological investigation to take site-prevent specific intervention. And at times, remember, trichomoniasis can be the culprit also. So we have to keep that in mind as well. Urethral discharge in PLHIV is a surrogate marker for incidence of STI and denotes the following: changing sexual behavior of PLHIV community, presence of an infectious case in community, non-use of condom. The patient starts believing that ART is taking care of all these elements and there is no need to continue protected sexual practices. This is a fact. People think, okay, I'm taking HIV medicines, I'm taking ART, so I don't need to use the condoms. There lies the gap, because the person might get other STIs. They might get drug-resistant HIV. So it's always better, we should impress upon the patients to use condom as well. And as I said, let me remind you, all of you again, the condom has to be used, but it has to be used 100% with correctness and consistency. What are the complications and treatment of urethral discharge? It is given in gray kit in kit 1. The complications are epididymitis, periurethral abscess, urethral stricture, prostatitis, gonococcal arthritis, very rarely disseminated gonococcal infection involving many organs. And the drug of choice I've mentioned, it is azithromycin 1 gram, cefixime 400 mg, and both in single dose and administered in presence of healthcare personnel. DOTS treatment, diet to observe treatment, to ensure compliance and adherence. Follow-up on 3rd and 7th day. Partner treatment, contact tracing and treatment wherever possible. Abstinence or use of condoms for a week. Painful scrotal swelling. It is a complication of untreated or improperly or suboptimally treated urethral discharge syndrome. Patient presents with pain and swelling in the scrotum. The possible etiological agent would be gonorrhea and chlamydia. We have to treat for both the infections. The other differential diagnoses that can be thought of are the following. They can be infectious cause and non-infectious causes. Infectious causes of scrotal swelling are tuberculosis, filariasis, coliform, pseudomonas, mumps infection. And non-infectious causes are trauma, hernia, hydrocele, testicular torsion, and testicular tumors. If we take proper history, it would be easier for us to know the cause of this painful scrotal swelling, and that would be easier for us to treat the patient. The clinical manifestations are swelling and pain in the scrotum, pain or burning while passing urine, systemic symptoms like malaise, fever, history of urethral discharge. Treatment includes kit 1 gray kit, azithromycin 1 gram and 400 mg cefixime, all administered in presence of healthcare personnel for compliance and adherence. Apart from this, we have to give analgesics because there's inflammation, and we have to go for T bandage or suspensory bandage because we have to elevate the scrotum to reduce the pain. So if you don't do that, the pain wouldn't be reduced immediately. So suspensory bandage or T bandage for elevation of the scrotum is a must, along with analgesics. Follow-up should be on 7th and 14th day. Partners treatment includes contact tracing and treatment of contacts wherever possible. Abstinence or use condoms till resolution and symptoms occurs. Cervical discharge syndrome or cervicitis. It is mostly caused by Neisseria gonorrhea and Chlamydia trachomatis. It can be caused by trichomonas and genital herpes as well. An assessment of the risk status and speculum examination will help in making a diagnosis. We have to take menstrual history to rule out pregnancy. Risk factors associated with cervical infection include the following: younger than 21 years of age, multiple, that is more than one sexual partners in the last 3 months, a new casual sex partner in the last 3 months, current sex partner has a sexually transmitted infection, recent use of condoms by the partner. So there would be a needle of suspicion. The person might be suffering from cervical discharge syndrome. The clinical manifestations are yellowish discharge with bad odor, erythema of the external os. And if you go for internal examination, we would see there would be punctate bleeding on the cervix in a case of trichomonas vaginalis infection. If there are punctate bleeding spots all over the cervix, in a case of trichomonas vaginalis, we call that strawberry cervix. So that is known as strawberry cervix. There might be burning while passing urine, increased frequency, dyspareunia or painful coitus, bleeding between menstrual period or metrorrhagia, use of treatment kit 1, gray kit, and the tablet of choice are azithromycin 1 gram, cefixime 400 mg, all under one packet and administered in the presence of healthcare personnel docs treatment to ensure compliance and adherence. Follow-up schedule 3rd, 7th, and 14th day. Partners treatment, contact tracing and treatment of contacts wherever possible. Abstinence or use of condoms for a week. Vaginal discharge syndrome. Vaginal discharge syndrome, we say, is from the vaginal area. It is not from the cervical area. So it is the vaginal discharge syndrome. The manifestations are cheesy white vaginal discharge, greenish frothy mix. There can be fishy odor, bad odor. We have to assess the quantity, color, odor of discharge, itching around the genitalia or the labia. The kit we use is kit 2 green in color, and a drug of choice is secnidazole and fluconazole. So we have to give 1 gram of 1 gram 2 tablets, that is 2 gram of secnidazole, fluconazole 150 mg single dose under proper the guidance, proper DOTS therapy, follow up on the 7th day. Partner treatment only if partners are symptomatic. Contact tracing and treatment routinely not required. Counseling education on personal genital and coital hygiene is necessary. Abstinence or use of condoms for a week. Take menstrual history to rule out pregnancy. Genital health ulcer non-herpetic. The causative agent mainly are Treponema pallidum, that causes syphilis. Syphilitic ulcers are usually worn. There's induration at the base, and it is usually painless if not secondarily infected. And that is the reason it is known as hard chancre. And you might have shorty lymph nodes also. You have lymph nodes in HIV also, for other genital area infection as well. For Haemophilus ducreyi causing chancroid, there would be multiple ulcers, that would be painful ulcers. It is dirty looking, that would be multiple, as I said, and it would be soft chancred. It is not hard at the base. And there would be Klebsiella granulomatis, or known as granuloma immunally, and Chlamydia trachomatis, or LGV, lymphogranuloma venereum. Syphilitic chancre is usually single painless ulcer, I've just told you, with induration. Though atypical presentations are common in HIV, multiple chancres may be present. Onset of lesion is after sexual exposure with an infected person. If herpes is suspected but not confirmed, then treat for both non-herpetic and herpetic causes. Remember that? If we cannot come to a diagnosis, we have to treat both. We have to give both the medicines for both the ulcers. On review after a week, if the lesion persists, the patient should be referred to an higher or competent authorities. Look at the picture. and the pictures of genital ulcer, single or multiple, painful or painless, burning sensation in the genital area, burning sensation in the anogenital area, injured or enlarged inguinal lymph nodes. Treatment is through kit 3. It is blue in color. It is white in color, and it is consists of injection benzathine penicillin 2.4 mega unit, given 1.2 in 2 butters deep IM after proper skin test. Azithromycin we have to add on by giving 1 gram single dose. If patient is allergic to penicillin, we have to go for kit 4, that is doxycycline BD for 15 days plus azithromycin 1 gram. If the mother is pregnant or is breastfeeding the child, doxycycline has to be avoided, erythromycin has to be given, and avoid treating pregnant. I've just told you, partner treatment should be given to all contacts for the last 3 months. Follow up on 7th, 14th, and 3rd month. Conduct physical and serological examination. Vaginal examinations are very, very important. And it's by kit 4. Syphilis and PLHIV. Although syphilis is uncommon in PLHIV, unusual serological responses have been observed among PLHIV who have syphilis. Neurosyphilis should be considered in differential diagnosis of PLHIV with neurological manifestations along with cryptococcal meningitis and TB meningitis. So PLHIV should be evaluated clinically and serologically for treatment failure at 6 month, 9 month, 12 month, and 24 months after therapy. Retreatment is considered after CSF testing be considered for person in whom non-tribunal test titers do not decrease by 4-fold within 6 to 12 months of therapy. We have to go for RPR or VDRL. Genital herpes or genital ulcer herpetic. Herpetic ulcer are caused by herpes simplex type 2, are usually painful or multiple, comes in crops. The lesions present a small vesicle that break down to form erosions or ulcer. And in patients presenting with genital ulcer, look for presence of vesicles or history of having them in the past. They might give you a previous history. Usually there are prodromal syndrome symptoms before eruptions of vesicles. What are the prodromal syndromes? Prodromal syndromes are pain around the genital area. There might be burning sensation around the genital area. There might be itching. So something is coming. Something is in the offing. So after that, you have blisters. Multiple blisters you have, which might erode and from erosions and which might lead to ulcers. Next is if the vesicle loss. Hello, am I audible?
Yes, sir.
Okay. Okay, thank you, ma'am. If the vesicles are superficial erosions with history of vesicles are noted, then the patient should be treated for herpes for a week. Recurrence is common. Erupted vesicles are multiple and painful. It can be present as a multiple genital ulcer with possibility of burning sensation in the genital area. The treatment is with treatment red color kit, that is kit 5. Kit 5 is acyclovir 400 mg, TDS into 7 days. The partners of those with herpes should be examined and treated only if symptomatic. RPR, VDRL should test depending on what is available. All reactive samples should be tested for titers. All individuals in serologically positive, irrespective of titers, should be followed for a serological cure and possible treatment failure. High titer syphilis is a marker of change in sexual behavior of the community or geography from where the patient has come. So remember, we have to go for counseling, and condom use is a must. So remember, just because having HIV and having STD, the case is over, not so. We have to remember the important pillar is counseling with condom use. Condom promotion is very important. Follow-up and partner treatment. Follow-up on 7th day. Repeat serological study of those who had positivity for syphilis serologically and treated with kit 3 or kit 4 to assess the impact of treatment. Partner treatment for herpes only if partners are symptomatic. Contact tracing and treatment routinely not required. Counseling and education on safer sexual practices. Abstinence or use of condoms for 2 weeks. All pregnant women with herpes infection should be referred to OBS and gynae specialists. I just missed something. That is, when you have syphilis, chancroid, if the pregnant lady is infected with, if the patient is RPR positive or VDR positive or having genital ulcer, she should, after delivery, she should come within 7 days to the obs-gynae department. The child should be treated. Otherwise, the chances of congenital syphilis is very high. The child should be brought back to the gynae department or pediatric department if the mother is found to be positive during pregnancy. It is very, very important within 7 days after birth. This I've told you. I've told you this. Now is lower abdominal pain or pelvic inflammatory disease in female. I told you how would I define pelvic inflammatory disease in female. That would include any infection above the level of cervix. That includes endometritis, salpingitis, tubo-ovarian abscess, and peritonitis. And what are the symptoms like? There might be fever, vaginal discharge, menstrual irregularities like heavy irregular vaginal bleeding, dysmenorrhea or painful bleeding, dyspareunia, painful coitus, dysuria, tenesmus, low back ache, and cervical motion tenderness. Treatment with a yellow kit, that is kit 6, and the common infections responsible for PID are gonorrhea, chlamydia, mycoplasma, Gardnerella, and anaerobic bacteria. So the kit we have includes cefixime 400 mg single dose, metronidazole, that is 400 mg into 14 days. But remember, when a person is taking metronidazole, should be avoiding alcohol. We know this because of disulfiram reaction, we should not be giving. Tab doxycycline, pregnant lady should not be taking doxycycline. And follow-up schedule is on 7th, 14th, and 21st day. If the pain and discomfort have not reduced or relieved at day 3, then the clinical diagnosis needs review. Partner treatment, treat male partners with kit 1, contact tracing and treatment required. Counseling and education on safer sexual practices are very important and forms a pillar in this sector. Abstinence and use of condoms for 3 weeks. Inguinal bubo. The common infections responsible for inguinal bubo are lymphogranuloma venereum and chancroid. Otherwise, inguinal bubo can be painful also at times. Swelling in inguinal region may be painful. Preceding history of genital ulcer or discharge might be there. There might be systemic symptoms like malaise and fever. There can be a groove sign. When there's granuloma inguinally, you will see a groove sign due to the inguinal ligament. And the treatment includes the black kit, that is kit 7, doxycycline 100 ml into 21 days, plus azithromycin 1 gram single dose. Follow up on 7th, 14th, and 21st day. And the partner treatment includes contact tracing and treatment required. Treat all contacts of the past 3 weeks. Counseling, education on safer sexual practices. Abstinence or use of condoms for 3 weeks. Aspiration if the bubo shows signs of rupture or breaking. Try to avoid formation of sinus. Out here, I want to add something more. Do not incise the bubo, that would lead to a sinus. Just take a needle with a high bore, go from a healthy skin and non-dependent area and aspirate the bubo, not from a dependent area that would leave a formation of a sinus. That is to be bear in mind. And what are the complications of STI in a case of women? There can be miscarriage, premature birth, ectopic pregnancy, increased risk of cervical cancer. Who are the causes of cervical cancer? Human HPV, human papilloma virus, and that strain that causes these cancers are HPV type 16 and type 18. And in men, there would be epididymitis, rectal fistula, urethral stricture, and fistula. both men and women. There might be fertility or infertility, increased risk of HIV transmission, 5 to 10 times more. Late stages of syphilis can affect heart, brain, and sometimes cause death. We know about primary, secondary, and tertiary syphilis leading to cardiovascular syphilis and neurosyphilis. There might be disseminated gonococcal infection leading to carditis, arthritis, synovitis. Newborn might have neonatal syphilis, ophthalmia neonatum, laryngeal papillomatosis due to HPV, sorry. Anogenital warts, they can be perivalvular warts, penile warts, and perianal warts. Causative agents are HPV, and the clinical manifestations are single or multiple soft, painless, pink in color, cauliflower-like growths. There will be varicose border, uneven borders. There will be varicose surface appeared around the anal, vulvovaginal area, penis, urethra, and perineum. Warts could appear in any other form, such as papules that may be keratinized. Most of the small warts disappear after initiation of ART as the immunity improves when there's immune reconstitution. This is another picture. Diagnosis and treatment are condylomata lata of syphilis. Condylomata lata is these are flat papules found in moist area. This is around the anal or perianal region. This is found in secondary stage of syphilis. And molluscum contagiosum is another DD of HPV. And diagnoses are with initiation of ART, most small warts disappear due to immune reconstitution. And treatment of larger warts are chemical cauterization with 20% podophyllin and compound tincture of benzoin, cryotherapy with liquid nitrogen, solid carbon dioxide or cryoprobe, electrocautery, and surgical excision. Key counseling messages to patients with HIV infection. Genital HPV infection is very common. Many types of HPV are spread through genital contact during vaginal and anal sexual contact. HPV can be spread by oral sexual contact as well. Usually HPV infection clears spontaneously. Some infections do progress to genital warts, precancers and cancers, and they are HPV type 16 and type 18 that causes cancers. And types of HPV that cause genital warts are different from the types that can cause anogenital cancers. I've just pointed that out. HPV vaccines are available now, which offer protection against the HPV types that cause cervical cancers and genital warts. People with genital warts should refrain from sexual activity until the warts are cleared or removed. Molluscum contagiosum caused by pox virus. Facial molluscum or giant lesions or multiple lesions are one of the HIV defining criteria. There would be a needle of suspicion towards HIV infection. Clinical features are multiple smooth, glistening, globular papules of varying size from a pinhead to a split pea can appear anywhere on the body. Basically, it's like a pearl. If you have seen mukto, it's like pearl. And it's glistening, and there would be central umbilication. The central point of this pearl would be depressed. Central umbilication is there. So it's like a pearl-like structure, pearl-like lesion. So it would be around genital lesion, but it can, these are not painful. It can appear on the face as well. And when the lesions are squeezed, the cheesy material comes out. And it is clinically based diagnosis, and treatments are individual lesions regress without treatment within 9 to 12 months. But we can go for de-roofing by needling, followed by chemical cautery with 25% phenol solution or 30% trichloroacetic acid. Ectoparasites, ecto-infections, pediculosis pubis or thyrus pubis. Clinical features are there may be small red papules with tiny central clot caused by lice irritation, thyrus pubis. General or local urticaria might be there with skin thickening, may or may not be present. Eczema and impetigo may be present. Treatment recommended regimen is permethrin 1% cream, rinse applied to the affected areas, washed off after 10 minutes. Special instructions, retreatment is indicated after 7 days if lice are found or eggs are observed at the hair-skin junction. Clothing or bed linen that may have been contaminated by the client should be washed and well dried or dry cleaned. Sexual partner must be treated along the same line as well. Scabies caused by itch mite or Sarcoptes scabiei, and you might have a genital scabies, and there would be clinical manifestation includes severe pruritus, itching experienced by the client, which becomes worse at night, and it usually appears on the crevices and cracks of the body, especially in the webs of the fingers, which becomes worse at night. Other members of the family are also infected. Sexual transmission to the partners, other members get infected through contacts with infected clothing and fomites. Complications include eczematization with or without secondary infections and urticaria. Treatment are with permethrin cream 5% applied to the all area of the body from neck to down and washed off after 8 to 14 hours. Benzyl benzoate 25% lotion to be applied all over the body below the neck after a bath for 2 consecutive nights. Client should be bathed in the morning and have a change of clothing. Special instructions, clothing or bed linen that have been used by the client should be thoroughly washed and dried well in the sun. Otherwise, fomite might spread infection. There would be snowballing kind of thing. And family members and sexual partners must be treated along the same line at the same time. Norwegian scabies, also known as crusted scabies, is an infestation characterized by thick crust of skin that contain large number of scabies, mites, and eggs. It is very, very infectious. It is a severe form of scabies that occurs in people who have weakened immune system. So treatment includes treatment of crusted scabies can require oral medication along with multiple application of scabiecide cream. Norwegian scabies is treated with topical permethrin cream and the oral medication ivermectin. Safety of ivermectin in children weighing less than 15 kg and pregnant women is not established, so we are not sure. Dose of ivermectin oral drug is 200 microgram per kg single dose and repeat dose after 2 weeks. STI control and prevention objectives are interrupt the transmission of STI that would interrupt or reduce HIV transmission. We have to remember 95, 95, 95. Early diagnosis and appropriate STI treatment. We know that would again reduce HIV transmission, prevent complication and sequelae of STI, prevent parent-to-child transmission of HIV and syphilis, reduce HIV infection risk. We have to think about risk reduction and behavior modification. Components of STI control and prevention includes creating awareness. We have to think about red ribbon clubs now in different organizations. We have to spread red ribbon organizations, red ribbon clubs, so that general masses are also aware of this. Promoting early health seeking behavior, treatment following syndromic case management protocols, ensure compliance to treatment. This is very important. Management of contact tracing and treatment of partner, counseling for behavior change and education on safer sexual practices. Condom promotion and provision forms an important pillar in this category. That includes social marketing of condoms as well, clinical follow-up, and documentation and reporting. Without proper documentation and reporting, we want to know what is when and what is going where. Condom promotion program includes increase condom use as a barrier protection, increase the number of condoms distributed by social marketing programs, increase the number of free condoms distributed through STI clinic, ICTC, PPTCT, ARTTI facilities, increase access to condoms and lubricants, especially to MSM and TG. Out here, I can use the word, if a person is using a latex condom, no use giving them we have to give them water-based lubricant. You know, if you give oil and cream, they would lead to ruptures. We have to know whom to give what, and increase number of commercial condoms sold, increase the number of condom outlets in strategically located hotspots for solicitation. Role of male circumcision in preventing HIV transmission. It has been seen that voluntary medical male circumcision reduces 60% chances of HIV transmission. I said voluntary medical male circumcision reduces 60% of chances of HIV transmission. Why is this foreskin more prone to HIV infection? Because it contains more accessible HIV-1 target cells, which includes CD4 T cells, macrophages, and Langerhans cells. And we know Langerhans cells in the foreskin are closer to the epithelial surface, which are more prone to injury or abrasion, and are the first to be infected by the HIV. An inner mucosal surface of the foreskin shows greater infectivity than that of cervical tissue, which is a known primary site of HIV acquisition in women, causing increased risk of genital ulcer disease. So I would end my session. So I need to first, any question? Hello?
Thank you so much, sir, for facilitating this session. Sir, we don't have any questions in the chat box. Any questions from the participants? Please feel free to unmute your mic now. Mic access has been given to all. Any questions from the participants? Yes, the recorded link will be shared soon.
So I need to thank Sweta ma'am and the iTech team.
Thank
And
you, sir.
Sweta
Thank you
ma'am
so
and
much
iTech
for
team are
facilitating this session.
always there with us. They are always helping, especially me. Thank you, ma'am, and the team.
Thank you so much, sir.
And thank
No,
you, Sui.
we are at a more benefit, sir.
Okay. And I thank you, Ismail Ji, Mr. Ismail, and Sui STM for helping me. And I wish everyone a happy festive season ahead. Navaratri and Durga Puja. God bless each one of you.
Thank you so much, sir. Happy Navratri and happy Durga Puja to everyone. Hope we will have one more RDLS session to interact with everyone. Thank you, sir. Thank you so much.
Thank you.
Thank you, everyone, for your active participation. Thank you.
Thank you.
Any questions? We'll end the session now.